introducing myself.
This meeting is being recorded.
And then I'm sure Dr. Goma would introduce himself as well. So hello, my name is Dr. Abibo. I'm actually here at the Medical College on faculty. I'm an internal medicine and pediatrics hospital medicine doctor. I've worked with a couple of you. I see some people in the attendee list that I've worked with. So that's what I do sort of in the daytime. And then for my scholarly work, I do global health work. My global health work is in Nigeria, southern Nigeria, which is where I'm from, which is where my family is from. The reason I picked sort of the topic, so I currently, my work is in diabetes. I wanted to pick non-communicable disease for multiple reasons. Number one, I do have, there is an impact of diabetes, within my family. I have some family members who have suffered from diabetes, succumbed to diabetes, had a lot of the long-term sort of effects of diabetes. So that's sort of why it was close to my heart. And then when you sort of look at the global health space in terms of the people that are participating in it, there's been a lot of focus, rightfully so, in communicable diseases, infectious diseases. And so the data is now sort of favoring an epidemiologic transition from non-communicable, from communicable diseases to non-communicable diseases. So that's one. So there's a need for sort of more experts sort of in that sort of chronic disease space. That's one. Secondly, in sort of looking at diabetes within Nigeria, I've actually seen there's an exponential growth over the past 20, 30 years. Dr. Goma would probably speak a little bit more about this, but the numbers have sort of, increased. While the numbers are increasing, we're finding that health literacy is still pretty low. We're finding that access to specialists is still pretty poor. We're finding that self-management behaviors are pretty poor, including, one of the studies that I was looking at recently showed in about a 4-year time period, a multi-center study, only about 70% of, 70% of people did not self-monitor their own blood sugar, so they didn't really know, what to do from a personal standpoint. And that's the least of, and then if you look at the impact, a lot of people are having nerve damage, kidney damage, strokes, diabetic foot ulcers, et cetera. So the impact of diabetes within Nigeria is pretty high. I did meet some experts and local experts over there, had some conversations with people about what are some of the challenges that are going on with diabetes management locally. Some of the things that they did mention, so obviously, from a overall political standpoint, the priorities are a little bit different, where there's not a lot of money being put into sort of chronic disease management or the healthcare sector at this time by the government. So a lack of political will to sort of support some initiatives going on. You have that. They talked about access being an issue as well nationally. They talked about, poor health literacy, but they also did talk about sadly, some of the things, there are some infiltration into the market of some medications that are adulterated, that are not actually pure medications. Then you have your, your alternative medicine as well, which is sort of providing, there are some myths in terms of, how people get to manage their diabetes. So there's a lot of cultural, layers of things there. So in discussing with them and looking at what are the possible interventions internationally to do, diabetes self-management became a very attractive intervention for me, because there's a lot of data here in North America and also in different parts of the world showing that diabetes self-management education, when it's standardized, there's sort of like a certain different areas that we look at. There's sort of a science to developing a good program for self-management education. And when it's done well, you can have a reduction in one of the parameters we look at, hemoglobin A1C, by approximately 1%. So in seeing that elsewhere, we sort of hypothesized that if we sort of adapted a similar program, obviously culturally tailored it with the help of the local experts, dietitians, we might be able to accomplish something very similar. So we had a very small, tiny sort of sample size about 3 years ago, and actually did show some beneficial impact. So my work right now is sort of increasing sort of the reach of that program. And additionally, in increasing the reach of that program, we want to see if we can actually train more diabetes educators locally. So in that sense, we're doing some local workforce capacity building as well that has sort of benefit them locally as well. So this is the work I'm doing. I'm going to let Dr. Goma speak. He has obviously decades and decades more experience than I have. It's actually one of my, I've been to him for advice a couple of times, so he can share some of the stuff that he does, and then we can now have a discussion about different aspects of global health. So I'll pass it over to Dr. Hector-Goma.
Thank you very much, Lolia, and for everyone for inviting me to join you. I live in Leeds in the United Kingdom in the north of England, where currently Storm Eunice is battering the country. So my background is I graduated medical school in 1989, and I've done quite a few things. I wanted to be a surgeon, then I wanted to be a physician, and then I went into public health, as it were, doing quite some work there. And then I went into radiology, and I did 3 years in radiology, and I had just 1 more year to become a consultant before I came into the United Kingdom to do a master's in health promotion, which is my passion actually. And then from there, I got into general practice or family medicine, as you call it. So I've really gone round. And so I've been a general practitioner for 14 years, and I've been a doctor for 32 years. And over time, two obstetricians have kind of a fundamental impact on my preferences for health. One is both of my emeritus professors and former vice chancellors. I mean, they were one of them, Emeritus Professor Kelsey Harris, in an entire edition of the British Journal of Gynecology Gynecology was dedicated to his work in 1986. 22,600 consecutive deliveries in the Zaria area of northern Nigeria, an entire edition. But when he retired from Obs and Gyne after 40 years, maternal mortality was actually worse in Port Harcourt at his retirement than when he started. And the same thing with Professor Nimi Briggs is again an astute professor, after being a professor of O&G, went into university administration. One of the topmost doctors I've met, like a mentor to me. And when he was leaving his valedictory lecture, everything said and done, he said the best way to reduce or minimize maternal mortality is education of the girl child. And that's after 40 years of delivering babies and doing everything clinical. And that really has been a big impact on me, that at the end of the day, the most important things that impact the lives of people are not medical interventions, they are social interventions. And that's why all over the world, where a country's socioeconomic indices are poor, the health indices are poor. So while it's great to have doctors and nurses and hospitals and facilities, education, good roads, skills, employment, that's the best way to improve people's health. And if you don't remember anything I say today, I want you to remember that it's great to have MRIs and all the singing and dancing tech in medicine, but the bottom line is the social determinants of health. The non-health sector has a bigger impact on health than the health sector. And once you have that understanding and you put that passion into whatever you're doing, then you are more than able to touch what Michael Marmot in the United Kingdom calls the cause of the causes. The root cause of people's problems is not medical, it is social. So while I was doing my radiology training in 1994, I set up an NGO, and the main reason for doing that was because I went to my village on holiday, and a young girl in my choir, I used to sing a lot in those days, was pregnant, and then she went and had a termination and became septic. And that was what got me to doing the so-called ABC of sexual health. So I went to about 50 or more secondary schools giving talks about the ABC of sexual health: abstain, be faithful, or use contraception. And while doing that, I was reading for my radiology exams and all that. And I got a scholarship to come and do a master's. And that's how I came to the UK in 1996. So that's just my background. So I have practiced medicine for this long, and currently I'm clinical director of my primary care network, which is about 30,000 patients from 3 primary care practices, and although a lot of the work we are doing is a clinical work, but my heart and soul is on about 50% of my population is deprived, 50% is comfortable middle class. And for the 50% that is deprived, a lot of their problems, whether they are diabetes, we have high levels of diabetes, of SMS and serious mental illness, and then childhood obesity. These problems are linked to poverty and lack of opportunities. And I keep saying that it's fine enough talking about SGLT2 inhibitors and GLP-1As, and all of that is great, but these people have issues about poor achievements of their children in school, lack of job opportunities, and all of that. And unless we deal with those problems, we just keep putting sticky tapes on a serious social problem.
That's so awesome. Thank you so much, Dr. Goma. So before we get into the Q&A portion, I do have some questions we're just going to be discussing. I see Professor Rosemary Ogu. Dr. Goma, is that?
Yes, Professor Rosemary Ogu she's the head of obstetrics and gynecology in University of Port Harcourt Teaching Hospital. And I'm sure she has over 100 papers to her name. And anyway, so Rosemary, it's good to have you here.
Okay. All right.
Thank you very much. It's a pleasure to be here.
Awesome. Thank you. So, all right. The first question, I think, Dr. Goma, you already sort of addressed a little bit. How do you define health? So I know you did. So we're talking about global health. So before we sort of talk about, all of us that love or are interested in global health, obviously we're interested in having equitable health across. We believe one of our fundamental values are that all people in all places of the world should have access to basic healthcare. At the very basic, that's why we're here. But how do you define health? And Dr. Goma, you already started talking about some of the social determinants of healthcare. So I'll let you continue with that.
Right. Okay. My favorite definition of health is everything that you do to keep people away from doctors and nurses. That's my favorite description of health. So if you look at my Twitter strapline, is that what we do in the health sector is to try to repair failed health. So when you say the National Health Service, for example, in the UK, is a misnomer. People think that you have to come to GP surgeries or the hospital to have health. It's only when your health has failed largely. So everything that can be done to keep people away from doctors and nurses in a nice way is health. I mean, the World Health Organization, as we all know, defined as not just the absence of disease or infirmity, but a state of physical, mental, and social well-being. And it's important to note that it's not a state because we are not static. It's a dynamic situation from being well to being critically ill. And we are all somewhere along that continuum. Same thing with the mental well-being, either you're mentally well or you're in crisis. So we are all somewhere along that continuum. So when you look at, I like to use the word well-being for health, because when you say well-being, you keep doctors and our interventions away from well-being. So whatever people need to do to be well, it's what I consider health. So that comes to the issue of giving every child the best start in life, getting all their neurotransmitters working well, all of that stuff. Good homes for people to live, warm homes in cold weather, cool homes in warm weather, go to schools where they have the opportunities to utilize every aspect of their body, to exercise their brains, and then have skills either to go to get vocations or to go on to become professors of neurosurgery or whatever. And then bottom line, having money in their pockets where they can make decisions. Most times people who don't have money in their pockets cannot make lifestyle decisions. So I say the bottom line is money in the pocket and it can make choices. And that's what I think health is.
Okay. I don't know if Professor Ogu, if you have, please feel free to jump in at any time if you do have something to add to anything we're talking about. I can go on to the next question. I wanted you to share, Dr. Goma. So being a native of Nigeria and your work is in Nigeria, me too. Do you experience culture shock with your work in global health, seeing as you've been in the United Kingdom for so long, and how does it affect your practice when you go back and do interventions?
One of the problems that we have is as if, it's like having, where there's a smell and you're there, you notice the smell initially, and after a while you have fatigue. The olfactory nerves just stop sending messages that the brain blocks it out. So most of my colleagues at home are practicing medicine under such unimaginable situations that sometimes they become numb to the problems around them. And then when we visit, and we have this kind of, I won't call it a guilt feeling, but we have this desire to give back. A lot of us who are here, I came to the UK at my age 30. So all my medical education, my initial training, all that was provided by my country, Nigeria. And I'm here in my 30s, 40s, 50s, giving it away to foreigners. And we all have this desire to give back. And of course, there are colleagues who are working there. I remember, let me just digress. In 1997, 96, I was doing a qualitative research on leadership and working together. And I spoke to my provost of the medical school and said, what does it take to be a good leader? And he made a comment that you work round the clock in the hospital, that your salary is not even enough to pay your bills. So you leave work at 5 and you're dashing to a private practice just to work extra hours to make ends approach because they'll never meet. So that there's never a time to just take a step back and to reflect on the work you're doing. And that's the example I want to give, so that when we now go there, sometimes our colleagues say, oh, you're coming with highfalutin things. You say, let's do some basic QI. People are trying to survive. You're talking about QI. So many times people don't show interest simply because what they are going through is overwhelming.
So Anna Coruja Ramirez asked a wonderful question that I wanted to see how we can answer this. So how do you not become jaded in the face of so much suffering on a daily basis? How do you stay grounded? That's a very fantastic question.
I'd like to ask Professor Rosemary Ogu. Maybe she could share what happened today in her labor in the theater today. Rosemary, do you mind telling us what happened in your theater today, if you don't mind?
No, I don't want to share.
All right.
I don't want to share, but I would like to say something. When you say how do you not get jaded when you see so much suffering or so much things not working out, I think there's this strength that you have as a doctor. If you truly believe your calling as a doctor to help, to give hope to others who come to you, then you just find yourself doing that. And no matter what the circumstances are, no matter what the scenario is, you don't give up. You just continue. And that's something like what happens today. We had this patient, terrible scenario, and in the end everything worked out, and I was so happy, she was so happy, family was so happy, and it was just amazing. And that's what we do as doctors. So you don't give up. You have that inner quality, you have that strength that just makes everything work out well. And then you have people who you can rely on, you have backbones, people who talk to you, who encourage you, who give when you least expect, when you don't even expect help. Somehow that help comes, and that keeps us going. Thank you.
Thank you. Somebody, Antonio, asked a question. It says, Dr. Goma, what tactics have you used to inspire change within organizations and amongst people who, like you said, are overwhelmed and do not look for change? So how do you then inspire change, and what tactics do you use?
Yeah, I mean, one thing that is key in terms of leadership, is to be able to influence people. I mean, over time, again, I'll just mention this. I run a charity. I've been in one part of the trustees for 13 years, and we're trying to make things happen in one of the communities in Rivers State in Nigeria. And one of the things I know is about being authentic. I think when I look at my personality, I'm visionary, and then I have kind of I'm a people's person. but I'm poor, I'm not operational. So I have the head and the heart, I don't have the hands. So I can paint a picture of what good looks like, of where we can get to if we don't give up. And then I can also sell the benefits to the people. So for example, if our system is upside down, and I won't just say, we need to do this. I could say, if we do this, this is the benefit to us as an organization. I always look at what the benefits to the patients, the benefits to the staff, and then the benefits to the wider system. So one is to paint the picture of what good looks like. And sometimes people are selfish because, like we said, because they are just overwhelmed. So I want to say, if we do this, you won't spend 30 minutes clocking a patient. Perhaps 10 minutes will be spent by somebody else doing this because of the change we bring. So that's one thing I think we try to do. And then also to be as, in terms of communication, to come, I mean, most times I know exactly what they are going through because I'm there, but to wear the shoes. I mean, like in my practice, for example, I told the patient support team member, the receptionist, she's worked so hard today. And I said, I'm going to try to save some money so that I can get you your favorite bottle. And she sent me a message back, saying that she really appreciates this. And I could have just said, well done, but I wanted her to see that what she had done today was exceptional. So painting the picture of what good looks like, talking about the benefit to the individual, and then just continuing to, like we always say, it's not a sprint, it's a marathon. And that is to celebrate the little steps. And I think Obama once said, building block by block. So even if it's a story building, even if we're going at a Linton level, let's celebrate every step we take along the way. And then there will be, of course, like sinusoidal waves, there'll be ups and downs. But if we don't give up, the good book says if we don't give up, one day we'll succeed.
Yeah, that's good. So I think it's a good segue. I know, Dr. Goma, what thoughts do you have? So there is this sort of temptation in global health where you're going into a new society, you see it as resource poor, and you're like, oh, it should happen this way. But there's something like the Messiah effect that can have like a negative impact too. So can you discuss, have you had any experiences with that? Can you discuss sort of what the danger is? And so with obviously globally minded people who are sitting here listening to us talk, how can we fight against that, and how is it actually received when you come in, like, oh, I'm going to bring all of this solution to this resource poor setting? It can be positive, but it can also have negative effects. So this Messiah effect, can you discuss a little bit?
That's a very good point. I mean, let's start with Nigeria. I mean, there are various countries in Africa who have different levels, but Nigeria, as you all know, is a rich country. Nigeria is not a poor country, it's a rich country. All we have is mismanagement of the resources of the country. 70% of Black doctors or more in America, I think, are Nigerians. And Nigeria is a wealthy country. Even though I've lived here now for 26 years, there are homes I go to in Nigeria that I will be intimidated. They have 15 cars, the kind of leather chairs they have, that the best marble floors and all that. So we have that level of ostentatious, vulgar income in Nigeria. And then you have those people who don't have anything. All they have is a cardboard to sleep on under a bridge. So we have that vast, expanse of people. Wherever income gap is wide is a problem. Then many people like Professor Rosemary and so many other, consultants and doctors, they know what to do. They just don't have the resources to make a difference. However great your ideas are, if you don't have the resources, you can't do much. And that's why many of us come abroad and we excel where we are. It's just because we come to a place where you can express yourself. So many people want to come over to Africa, to Nigeria, to come and, bring the light to us. And I say, the generator is there. There's just no petrol in it. So one of the things I guess you would do is to have an understanding of what is going on there first, kind of do a root cause analysis, and don't come, like they say, come with your eyes open and then with your mouth shut. And that way you can listen and hear, and then you can seek permission, to share what your thoughts are. But definitely people are very smart. They know what to do. They just don't have the resources at their disposal. And that's why many people are always talking about resources. because that's what they lack. They have the ideas, people are doing dinner sections with candle lights or with torch lights and all. Those are things that some people here could never dream of doing. So many people are doing the impossible with the very limited resources that they have. So the Messiah effect is many times is counterproductive. And it actually stifles, make people become, when I came to the UK, I raised about £100,000 for my charity in my first year in the UK. After that, I made up my mind that this is being donor dependent. And from 1997, I stopped trying to access grants. I said, whatever I want to do in my community, I have to raise it from my people in the UK, US, and all that, because then we can become self-reliant. So resource poor countries, when you bring resources, sometimes we'll become dependent on them. And the day that money dries up, the whole project dies. And that's why sometimes the Messiah effect is counterproductive.
And that goes into the topic of sustainability, which we'll talk a little bit about some ideas of, how, and you actually did talk about one idea of, how do you develop sustainability within projects? Let's see. Okay, so we talked about the Messiah effect. So segue from the, actually, I was going to make a comment. So one thing that I've noticed sort of in my, few years of practice and trying to do stuff with global health, sometimes the solutions that we bring may not actually fit. So we have this sort of external view and you're like, okay, yeah, but this works like this here and this works like this here. So obviously it should, do the same thing in another country, but there are so many different layers, the culture, the workplace culture, the political sort of culture, the access to different things. So not all solutions we bring. So it's always good when you're, you have all these ideas to actually, like you said, do a lot of listening, observing, and actually run it. You want to be more of a partnership with local healthcare professionals than going to say, well, I have the solution to your problems, but actually say, hey, do you think from your experience of your daily day-to-day practice in this local culture that this suggestion or, program or whatever I'm bringing over will actually help? So it's always nice to have their collaboration and their input because they would actually know more than you in terms of the fit. How does it fit into the culture in terms of the solution? So moving on, this Messiah effect. So what is a good way? So if you're not going in there and you need to listen, what is a good way to sort of establish and maintain over the long period of time relationships with healthcare professionals and quote unquote resource poor settings? So what do you need to do for a successful long-term relationship with your global partners?
I guess one thing that it's important is I like data in terms of knowing what the problem is. And drilling the data down to the barest bone of the problem and having a clear understanding of what the problem is. So start with the problem, get all the information you can get about the problem before you visit. And I think it's good to spend some time and do a root cause analysis of the problem from the point of view of those who are living there. And then you do your mapping, whatever it is, map the process. Say, for example, with diabetes, you map the process from being normal A1C, as we call it, to becoming pre-diabetic, to becoming diabetic, and then having complications. And then you can walk through with the partners there, whether doctors, nurses, whoever other stakeholders or other people are. And then look at every step of the way and see what the problems are and come to an agreement, working together. What are the possible solutions? Then you can check out your own experience here, what the solutions are here, and then you can challenge the thought processes and all of that. So at the end of the day, you come up with a plan of action, which is, as they call it, culturally sensitive, which looks at the reality on the ground. You have a process here where you 24/7 there's power supply, and then you have a place where you have 1 hour power supply. That's a different level. So what will work here perfectly won't work there. You have a system here where you have institutions which are well established, for decades doing things. Out there are no institutions. There's hardly any institution. It's what one man in power decides that takes place, whether that is the chief medical director or the governor of the state or the local government chairman. And if it's a good man or a good woman, if they're there today, they are gone tomorrow, the next person can do entirely different. So, and that's why I think taking the time out to work with the local colleagues, local people of influence, and then coming out to talk through and then have a plan of action. Don't come with a ready-made solution to try to put it out there. First of all, do a proper, a kind of a QI plan with those who are on the ground, and then come with a solution that they actually feel has come from them, and then they'll buy into it.
Yeah. And so there's so many, so I guess maybe this is a segue. How would you compare? So I sort of have my thought part. You've sort of touched on some of your examples of some of the challenges to local healthcare. For example, let's talk about Nigeria. You talked about electricity and the differences in electricity supply. Some of the other things that I also noticed with my work in Nigeria is even water. So one of the things that I noticed was in some of the clinics, endocrinology clinics, there was no running water for these physicians to, go in and wash their hands. And that's actually very interesting, because sometimes you'll be here in the UK or in, resource rich settings and say, well, infection control 101, you always want to wash your hands before and after every patient interaction. And so sometimes they're like, well, I'm going to go in, I'm going to challenge everybody, educate everybody, you have to wash your hands. And then you get to the ground, you're like, there's no running water in the entire clinic. So that's an example of, but what are other examples? What are some other differences? How do you compare the healthcare setting in the UK, for example, to the healthcare setting in Nigeria and even to the US? Because our healthcare system is different from your healthcare system because you have the NHS service. So can you draw some of those comparisons for us?
Right, okay. The National Health Service, I think I'm actually very proud of the National Health Service, 70 plus years ago, and it said that healthcare is provided to people based on need. That's the key thing. You access healthcare because you need it and not because you can afford it. And that's the I don't know how to put it. I actually get a bit passionate about it, that you get healthcare in the UK when you need it, not because you can afford it. And that's very different, I'm sure, from your system in the US, and it's very different from our system back in Nigeria. I'll use a particular example. I was a senior registrar in radiology in my hospital, and then my wife was going to have our first baby, was going to be an elective cesarean section, and she was given a long list of things to get for the cesarean section, which we had to buy. And then she was working in an oil company as a kind of a temporary member of staff, and even at that, she couldn't get those items, but the chief medical director grudgingly gave her everything she required and asked her not to come back for anything. And it's a member of staff, even though it was not fully, commissioned, whatever it was. So here I am as a registrar in radiology, working in a hospital. My wife was having CS. I had to go and purchase everything. And that's the sad situation. When I was a medical student, a woman comes with her child to the special care, to the children's emergency unit. Child is convulsing, and the doctor writes a prescription for diazepam, for needle, for syringe, for cotton wool. And if they dash out and come back and they forget something, it's changed a lot then. But that's just what to imagine that even a child who is fitting, that there are no emergency drugs in those. I'm talking about the 80s now, maybe those things have changed. But the point is, unfortunately, the UK system provides for everybody. Of course, the rich go to private clinics and all of that, but at least the NHS is there for the poor and then for every other person. And the other issue just to mention is that because you have to pay for everything, people now use different methods or different, you have, of course, the orthodox practice, you have the traditional practice, you have the informal practice. So your neighbor, your family member, everybody knows something about medicine. And you go through a lot of those other options. When all have failed, then you come to the hospital. And many times people come in later, and like Professor Ogu will say, they have a labor ward for booked patients because many people come in when things are a bit late for them. Yeah. So that's just what I'll say about the health systems, yeah.
And to add to honestly what you're saying, some of your observations, I know, we're talking about the 80s. I'll be honest with you, even as recent as 2 years ago, one of the patient, this is somebody I know personally, a patient had surgery and after surgery was decompensating, and the hospital did not have oxygen available. They had to ask the family to go to purchase oxygen at a point where a patient was hypoxic, and that caused some problems. And actually, the patient actually ended up passing away. So these are not old stories where you have to pay for every single thing, and if you cannot pay for it or purchase it, you have to leave the hospital, go and purchase medical equipment, come back for the care of your family members. So that still exists. And so for the other people sort of on this call, hearing, some of the solutions that we might have bringing in, you have to learn and study, what are the resources available in a particular area? Can this actually be done? And even as far as maybe 5 years ago, the same thing about if you want labs drawn, you have to go buy the syringes and the test tubes, bring it back to the hospital. They draw it for you, send you back with it to the labs, you get it run. I know that there are now some national centers, specific centers, but again, those are more expensive. So the average person probably cannot afford that level of care where everything is automated and it gets done for you, because you have to pay a deposit in order to get service when you enter a hospital. So it's so in trying to come up with a solution, you have to learn what's the culture, what's the layout, what resources are available, and you have to cater your solutions to what they can do. So Dr. Goma, the next thing I wanted us to maybe talk about is this whole concept of international workforce building. And I know sort of in the way that you work, I've talked to you about this before, and you like to, if you have an idea or something, a solution, you definitely, not only do you do it in a collaborative way, you actually do it in a way that your international partners do get credit or some sort of development or some sort of personal recognition for this. So can you talk a little bit about what role does international workforce building development play in global health?
Right. There are two organizations that one is quite proud of because of the efforts they've made. One is MANSAG. MANSAG is the Medical Association of Nigerian Specialists in Great Britain. So consultants and GP specialists, they kind of have this body. And then you have the American equivalent, which is ANPA, Association of Nigerian Physicians in the Americas. And I think both organizations have, in the last decade, they've tried so hard to try and set up things with the government in Nigeria, such that people could maybe find 1 or 2 weeks every year to go back and support a level of high level interventions, across the specialties. But unfortunately, what you see sadly is that many good ideas do not see the light of day, because I'm sorry to say this, but many of our leaders in the public sector are only interested in lining their pockets. So whenever there is an idea, their main interest is, can I make money out of this? And if they cannot make money for themselves out of that, because we who are here, we work so hard and we want to account for every penny or cent that we put into the system, we find it frustrating. And that's where I know they came so close to putting something together a few years ago, and then it fell apart the last minute. So what you now have is pockets of intervention, like in my community, there are about 100 doctors. We have a WhatsApp group, and every 1 or 2 years there's a medical mission. And, we here raise medical bags with various drugs and appliances and all of that. They get themselves together and then they do medical missions, do maybe 50 or more hernias and various surgeries and all of that, check blood pressures and things like that. So what you now have is some private hospitals in some parts of Nigeria, like Lagos, and then I'm sure even in Port Harcourt and 1 or 2 places, they now link up with Nigerian specialists abroad. They now arrange and bring them in at different times, line up the patients, and they do things. And while they're doing those procedures, our colleagues, improve their skills. And that's one excellent way. Then even something like telemedicine is still developmental because of the poor infrastructure around fast internet and all that. But Increasingly, there are one or two places where they have telemedicine booths where people can now do investigations and have a chat with their doctors there or doctors here. So talking about, just to digress a bit again, that is one area. Using technology and mobile health is one area where I think we can have a disruption of healthcare. I always wanted to do something around that, around cardiovascular health, diabetes and hypertension. We can set up algorithms and have servers and have people being able to access blood pressure results, send via phones, and then you can have a network of clinicians all over the world being able to access those results and give information back to people. And that's the kind of thing that even those in the village, everybody has a mobile phone of some sort that we could help to improve health that way.
Yeah, that's very interesting. Absolutely. So telemedicine absolutely is one, the internet, that's one of sort of the new, and I'm excited to see, especially with COVID, I feel like a lot of the global health interventions have now been forced to be telehealth and telemedicine. So I'm interested to sort of see over the next few years where that goes. One sort of example that I can think of with telemedicine too in workforce development is, one of partners here at MCW, one of the professors here actually does some work, I believe, Central Africa, and they train local people there on certain sort of surgical interventions, and then they remain on consult 24/7 via telehealth. So let's say they're doing their surgery and they have a complication or a question and quickly ask, how would you perform this? How would you do this? And they communicate that way. So I'm excited about the opportunity for global health or for telemedicine and what that will do to global health interventions. All right, so Dr. Goma, you made some comments about the politics and government. And so how do we, people who are interested and passionate about global health, how do we be careful in navigating those political relationships and some of those challenges that we face with the government leaders, knowing that our priorities may be different from their priorities, but what can we do to make sure that at least the patients, get some benefit, obviously in a moral way where, you're not crossing any moral lines, but, it's almost like you have to, they have to see what they can get out of it, politically speaking. So how do you forge a relationship where the patients actually do get value and benefit, but at the same time, you're still staying moral, but you're sort of navigating those political relationships? Do you have any sort of experience with this? Like you said, earlier, and we've had this conversation before, if you're doing something, let's say you have somebody in power now, and after they go out of power, the next administration of the government can come and totally kill whatever you started working on because it doesn't align with their political sort of values and priorities, or they don't get credit for it. So how do you navigate those sorts of things?
Yeah, it's a difficult terrain to traverse, but it's not an impossible place to go. Somebody said there's no bad person. A bad person is a good person waiting to be revealed. So having said that, and one of the things is, I think it was Leon Urus who once said, everybody has self-interest, and we must sell the benefit to the politicians. How this program is going to be an indelible mark for them, that even after they are gone, we'll still be singing their praises. So for example, if you want to renovate a ward, can you name that ward after this person's mother, for example, so that way, find out about their lifestyle and tell them, we name this whatever, this female gynae ward, as Rosemary there, after your mother. So that kind of thing, we say, oh, that's a good one. So many of us are altruistic. We do it because we feel it's a nice thing to do. For some people, is what is in it for me. So tell them, your elections are coming. If you do this, it's going to be a plus for you. And then the next thing is, everybody has somebody that can influence them. I mean, like Professor Briggs, who is my mentor, he's very well respected. If I want to reach anybody in government, I probably would ask him to speak to that person on my behalf, and they will probably listen to me because of him. And that's the next thing to do. And then the other point is that, coming back to Krika, we had 2 local government chairmen who were awful in the last 3 years. And they elected new local government chairman about 3 months ago. And in 100 days, everybody knows that these two men have done more in 100 days than the other two men together did in 3 years, in just 100 days. And these are two good men. So sometimes if you look out for people who are good and try and get them. So if you have 10 politicians, maybe one politician is good, try and get that one good politician to be on your side. You know, it may not be the health commissioner, maybe it's a works commissioner. Do something around works. And if he is on your side, then maybe other people can now feel a competition to try and be useful. Many of them, once they know there's no money in it for them, they will not be interested. But I think it will be able just to look around and find out who is good and how can we sell the benefit of what we are doing to them. And at that point, I was always saying that because I see politicians, whatever little money that is available is in the hands of the politicians. And these people get humongous monies for so-called constituency projects, humongous monies, you know, and I always say that it's important to try to get them to see the benefits of these little interventions. Like an example of childhood diseases, if there's a borehole in a poor area and there's good clean water there, then we're going to reduce diarrheal diseases amongst children in the community. So tell that person, if you put this borehole there, you won't have diarrheal disease in the hospital. The credit comes to you because of the water you've put. We can come back tomorrow and make a big announcement 6 months down the line, thanking you for the water you put, and I will cut down diarrheal disease in the hospitals. And I think we can massage their ego and get something from some of them, but it's a challenge. It's a big challenge.
It's a challenge. And honestly, so for everybody on this, you know, these are the realities of global health work, right? That we're talking about. These are the ugly aspects of some of the global health work that you would do. And this sort of ties us into, I think we should probably move on to talk about advocacy and policy development. So with all global health work that you do, they're always, I don't know that you always are relationship building relationships with your international partners, building relationships with your international patients, but also I think in order to, you know, going back to the word sustainability, in order to create sustainability, you have to have the leaders on your side. You have to be able to frame and build a project as for the benefit of not just the people. Sometimes, sadly, you have to frame that this will be the benefit of this particular government sort of regime, sadly. So you have to almost sort of be arguing, you know, this is what's in it for your people, but this is what's in it for your government, and this is what's in it for. You have to frame. So let's talk a little bit about advocacy and policy development, because especially with Dr. Goma, you know, this is sort of where it comes in. You know, when you do global health, there is, I don't know that there's a way to make global health efforts sustainable without the advocacy piece of it. And I don't know that there's a way to make that happen without changing policy. And so, you know, there's different ways that people obviously can sort of start getting into global health work. You can just decide, hey, I'm interested in a region, I'm interested in a disease. But I think sort of the sustainability aspects, that long-term, you know, creating change that will last for a long time, will have to do with changing policy, affecting allocation of resources within a particular place, and advocating for people that are, you know, underserved or, you know, don't have access to equitable healthcare. So Dr. Goma, any thoughts about advocacy? You've sort of touched on it a little bit in policy development. Oh, we have some questions. Oh, one more question, but so Dr. Goma, if you want to just talk about this, and then we'll ask this question.
Okay. I think we need to de-emphasize the medical aspects of the problems, like I said, and maybe the younger generation, we know, particularly those who spend a lot of time on WhatsApp, on Twitter, and all those places, we'll need to begin to talk about the role of politics, the role of the public sector. You know, of course, you have the legislative, executive, and the judiciary. So particularly the executive and the legislative arms of government, for them to begin to see their role in health. You know, like I was saying, that we need to begin to say more of health is keeping people away from doctors. Health is keeping people well. So begin to get that understanding that people, because the mindset people have is, I want to go and see the doctor so that I can be well. You know, and even again, coming back to a lot of the social issues are what brings our patients to see us. And I say, well, it's a housing problem. It's a refugee who's looking for his immigration papers sorted and all that. So I think with people, I mean, in the US, you're very good at lobbying politicians. People have a career lobbying politicians for good. So most NGOs I know have somebody who is linked to one politician to try and make, that particular statement that will make a difference. We don't have that as an organized thing in Nigeria and much of Africa. So maybe that's an area where people will begin to learn how to lobby politicians. When there are issues that are going to be voted upon, get people to begin to educate them, to get to their PAs and talk to them. If the PA understands it, he can pass it on to them. So we need to have a kind of a structured approach so that every politician that matters, people say, okay, this is coming up. Let's look at the river state. Let's look at the national level. Who do we need to target? And then put resources around targeting such people. And something that very simple, many people don't read documents anyway. So, but find a way to get information to them. Mm-hmm. And I think that's something that we need to do a lot more of to try and get politicians to see things. Unfortunately, there's this statement that politicians are only looking at the next election. Statesmen are looking at the next generation. And if whatever is happening has no relevance to the next election, they are not interested. And that's why most politicians are active in 2022 because the election is 2023. In the last 4 years, they've not done anything. So it's a big challenge, but it's not impossible that we need to actually learn from what is happening in the West to learn how to begin from the level or even the local government council. Nobody talks to anybody, but and they don't, many of them have no idea of the broad determinants of health. They don't have any idea. So it's to now find time. I know somebody was involved in doing workshops, and at the beginning of every executive year, they have workshops. So to find a way to be able to do a presentation when you have new people in government, to be able to have 30 minutes or, to try to let them know how water makes a difference, how good food in primary schools affects the grades, and if people have good grades, then tomorrow they're going to be useful to your city, and if they're useful to your city, health will improve, all that kind of thing. I think it just requires a new way of approaching politicians.
Absolutely. So I know we're running out of time. I just want to make a small comment about, so for you, when I was in residency, just for the students on this chat, I actually did participate in some local advocacy sort of events for pediatrics. So I med peds, so half of my training is in peds. So we actually would go to, this is in Michigan, we'd go to Congress and we'd actually go and say, hey, we'd pick a topic. So we had like a day, advocacy day, residency advocacy day. You pick a topic, it could be smoking, it could be vaccinations. Now with COVID, you could say, COVID vaccinations or whatever it is. And you actually learn how to engage in conversations with people that have the ability to affect policy and change things. So that might be a good practice for you guys to start locally with seeing how do you get into sort of the local sort of health issues and how do you engage lawmakers, people that have the ability and the power to have these conversations. That'd be a good place to start. And then you can think about international advocacy and international policy. So just really quickly, I know we just have like a minute or so. This person asked, are there specific times when you can advocate and politicians are more receptive, like election time? I would say yes. I would say yes.
Yes, there's one politician in who is now very visible in the last 6 months. It's so almost every day is something good, and it's just because elections are next. So yeah, definitely. Yeah.
Absolutely. So I think we're done, guys. Sorry, Max, we went all the way up to 12:58. So we are done. Any last questions for us or comments?
Yeah, I just want to thank both of you for doing this. I think your eloquence, your insight, your intelligence, your drive for what you do is just like contagious. I think everybody who has listened has felt that. I have one question before we all go, and that is for both of you. What are you most proud of?
Wow, that's a good question. I think what gives me greatest delight is that whatever I want to do today is based in health, is based on that principle, nihil de nobis sine nobis, nothing about us without us, and that we cannot make a difference in the people's lives without carrying them along. And that's something that I'm doing more of. I'm really proud of that.
And to say, I think for me, the work I did in Nigeria in 2019 absolutely changed my life. So just being on ground, interacting in the hospital, seeing the patients, and just sort of hearing their stories, listening to them was absolutely life-changing. And that sort of really gives me meaning and purpose. So just the fact that I'm able to do any kind of global health work, I would encourage everybody to sort of just travel, be out there, talk to people, talk to patients. It's absolutely life-changing, gives a lot of meaning. You'd realize how blessed you are with all the resources that you have, and that even very little, just giving your time, people appreciate that so much. So just being able to be out there for me is very meaningful. So
thank you both.